for future, and really pleased you're all able to join today. Before we get going, I just want to acknowledge that I'm coming to you today from Chief Dry Geese Territory. I'm in Yellowknife, Northwest Territories, and this is the traditional land of the Yellowknife Dene. And it is a beautiful time of year, although it was below -30 this morning. It's been a very cold winter. It is very lovely. We have a full slate for you today. And before we get going, I just want to, for those of you who are unfamiliar with networked health, just introduce you a little bit to what we are doing. We're sort of a collective of individuals across the country, and it's growing, who are basically trying to build person-centric health data ecosystem well-being of all Canadians. And I'm pleased to announce that Networked Health Ontario, our latest chapter, is just launching in coming weeks. So we have BC, Alberta, Ontario, and we're certainly welcome. We certainly are pleased to welcome new chapters if people want to join. A few other bits of news, and then we'll get to the topic at hand today. Many of you are probably familiar with Bill S5 being introduced in the Senate a little. We're very pleased this has happened, and we'll be having we'll be focusing more work on what this looks like with our partners and our colleagues across the country in terms of a regulatory framework. Also, I just want to announce that there's a spring conference that we partnered with the HIMSS Prairie chapter. And my internet. Problem. Tell me if my internet. So someone can put in a comment, is my internet lagging? Okay, I will continue. I will try to get a hotspot in a moment here, but I'll just get through this. I just want to introduce then what our topic is here today. And so we at Networked Health professions. This is a first in Canada, and basically it is an opportunity to collaborate across professions. And basically what it is a statement that health data and professional regulation, health data is essential for health professionals to provide high quality, accessible health data and deliver safe and effective care. And so this, it may sound maybe self-evident to some of you, but it is not a space where regulators have gone historically. So I just want to set the stage for this. What is the purpose of professional regulatory colleges? I didn't used to know before I work part-time at one, but they're often perceived as being sort of the police or sort of policing the function of health professionals. The mandate of health professional regulatory colleges is to protect the health and well-being of the public, or as it says here, and this is from the Alberta Health Professions Act, protect and serve the public interest. So this is achieved by assuring that all the health professionals promote health and well-being. Now, lastly, before we get going here, I will just say that we're not mandated to regulate health data. Is an essential component or an essential ingredient of coherent and health system, health service by health professionals. So what I'm going to do now is I will introduce our first speaker, and we have a series of people today. And this is Nicole Kain, so we can bring Nikki on. And I will stop my slides, and you can registered nurse, and she is a PhD in public health, and she works at the CPSA, and she's the Director of Analytics, Innovation, and Research at the College of Physicians and Surgeons of Alberta. And she co-authored a paper called Health Data Access, Quality, and Use, Factors Impacting Physician Performance. And I'm going to turn this over to Nikki. And this basically sets the stage through between health data and professional regulation. So Nikki, I will let you take this, and then I will try to find something to hotspot so my internet doesn't crash. Thank you kindly.
Okay, great. Thank you so much, Ewan. And hopefully my audio here is okay. I'm really grateful to this group for allowing me the opportunity to speak today. Today, I want to talk about something that might seem obvious, but that actually hasn't been treated as a formal factor in physician performance: the role of health data, access to it, the quality of it, and the application or use of it in practice. So first, I'm going to briefly ground this in some of CPSA's work on physician performance, and then I'll talk about what we think is a missing factor, health data, and why that matters for patient safety. Next slide, please. So a bit of introduction to who we are within the Analytics, Innovation, and Research Department, or the AIR department at CPSA. A major area of our work in AIR focuses on understanding physician performance in practice. So what supports it, what might put it at risk, and how regulation can actually improve the safety and quality of care. At its core, of course, our role as a regulator is to protect the public, and that means ensuring physicians are able to provide safe, timely, and effective care in real-world conditions. Next slide. Over the past several years, our work in collaboration with researchers and with stakeholders across the country has focused on understanding what drives physician performance in practice. For example, we identified a range of both risk and support factors, including individual and system level factors, from interviews with physician assessors from across the country. We've also contributed to a larger research group around pan-Canadian work that examines physician performance across jurisdictions. And in collaboration with our colleagues at the Medical Council of Canada, we've studied how licensing exam performance relates to real outcomes in practice, linking early indicators to real-world performance. So this work that I'll be discussing today, the paper that Ewan mentioned, builds on this broader program of work that's aimed at understanding what really enables safe care. Next slide. So across this work, we've drawn on what we refer to as the Cambridge model of physician performance, which was first delineated in 2002 by Raythans et al. In a seminal paper. The Cambridge model essentially says or tells us that performance is shaped by the confluence of three different domains: competence, individual factors, and system level factors. While most attention has been really focused on the first two, competence factors and individual factors, system factors are just as important, if not more challenging to measure. And they're also much less well understood. Next slide. So when we talk about health data and physician performance, it seems a bit obvious, right? If physicians don't have access to the right information, they might be more likely to make mistakes, and patients can come to real harm. Without needed data, physicians are compromised in clinical decision-making, in the care that they provide, in really all domains of physician services. And yet this has not been formally recognized as a performance factor. Next. So I'll spend a bit of time on this slide because I think this figure really helps to illuminate the direct link between data quality accessibility, and misuse, and how those contribute to poor physician performance, which ultimately results in health data related harm. So from this figure, we can see how determinants of physician performance, both competence and system factors specifically, can contribute to deficits in proposed health data factors, including the misuse of data, having suboptimal health data, and suboptimal health data quality, as well as accessibility. So in turn, those deficits can clearly be linked to multiple forms of health data related harm. And this figure is actually also in that, that publication that Ewan referenced, and I'll have a QR code to scan at the end of this presentation if you want to take a look at that. Next slide, please. When we talk about health data as a performance factor, we think about access to health data. In 2024, Canadian physicians reported spending around 90 minutes a day searching outside of their practice for needed patient information, highlighting major access gaps. Limited or delayed access to data is also linked to reduced diagnostic accuracy. For example, AI modeling studies actually show that missing data degrades clinical decision-making. A lack of interoperability means that critical patient information may be unavailable when needed, which contributes to medical errors and compromised patient safety. Next. When we think about the quality of health data as a performance factor, a meta-analysis of 23 studies found that high-quality data is essential for clinical decision-making and population health insights. In primary care, poor quality data leads to poor patient care and undermines research validity and public health surveillance. Clinical studies also show that access to higher quality data enables more accurate diagnoses, better prognosis prediction, and more appropriate treatment decisions. Next. When we talk about health data use or data literacy, evidence suggests that physicians are unconsciously incompetent in data use, lacking understanding of how data are generated, interpreted, and applied. Gaps in data literacy contribute to failures in documentation, in sharing data, and in the appropriate use of health data, limiting clinical care and system learning. Currently, Canadian training and competency frameworks do not adequately address health data literacy, which leaves physicians underprepared for data-driven care in a data environment. Next. So how does data lead to harm? Well, up until this point, I've really talked about health data conceptually as a performance factor. But here's an example of what it actually looks like in practice on this slide. So when data is missing or delayed, doctors are making decisions without the full picture. When data quality is poor, even good clinical judgment can be undermined. And when data isn't used effectively through documentation or sharing or interpretation, we lose both clinical insight and system learning. So these aren't just data issues, these are direct risks to patient safety. Next. So this leads to a pretty significant gap in terms of how we define performance. Regulatory approaches, as regulators, we tend to focus on competence, on conduct, and on clinical performance and practice. And yet we don't typically account for the data environment that shapes the decisions that physicians are making in practice. As our work shows, health data is not formally recognized as a performance factor, so we end up holding physicians or regulated members accountable for outcomes, while a key driver of those outcomes, which is the data environment, is largely outside both their control as well as our regulatory oversight. Next. So what needs to change? Well, if we accept that health data does impact performance, then the implications are somewhat straightforward. We need to explicitly recognize health data as a core performance factor We need to improve access, quality, and use. Those are the 3 dimensions we've outlined in the paper. And importantly, there's a role for regulators here. So not to manage data systems directly, but rather to engage in how those systems are both designed and governed. Because ultimately, performance improvement isn't possible if the data environment is working against clinicians. Next. So why does this matter now? This isn't just a physician issue, it's system-wide. The same challenges apply across health professions, which you'll hear, I think, reflected in the panel discussion following my portion of the webinar. And that's why I think this work is really gaining momentum. In Alberta, regulators across professions have come together to develop a shared consensus statement on this issue. So we are starting to move beyond just identifying the problem towards coordinated system-level action. Next. So there's the QR code to this paper if you'd like to take a look at it in more detail. And I will perhaps leave you with this, that health data isn't just a technical input into care. It's really a foundational determinant of whether care is safe and effective. So that's it. I have references on the last slide, but happy to take a couple questions if we have time right now.
So we can reserve the questions for later, Nikki. I'll just ask you a few things. And just for everyone here, now hopefully you can hear me better. I'm hotspotting now, so that was not great. Hallelujah, the beauty of the North. If no one's ever been to the Northwest Territories, our infrastructure is not always perfect. This was the hospital internet and it was breaking up. So fascinating, Nikki. This is great. So you say that as a clinician, and you can see I'm in a hospital right now, it seems odd that data issues were never considered as a factor, a performance factor. And yet I think most of us, and we'll hear from three people in a moment about their personal experiences with this, sort of relate to the fact that if we're missing information, it's difficult. Why did it take so long to recognize this?
I think as regulators, and certainly at CPSA, I think we've traditionally focused on those individual risk factors and those competence factors, partially because they're perhaps a bit easier to measure and pinpoint. But, I think it's so important to look at the system within where a physician is working, right? Including the data. So the data environment. And, again, like the result is we're holding clinicians, physicians, other healthcare professionals accountable from the regulatory sense for outcomes that are shaped by data environments that we don't oversee. So I think difficulty in measurement is one piece of it, but I think it's also, it seems a bit challenging to look at the system as a whole. But I think examples like today's webinar, bringing people together and having a consensus statement are really moving this work forward.
And we have an example in New York City a few days ago with some other professionals, that being pilots, where information exchange appears was not correct, and it led to harm to many people with that plane crash. And our prayers go out to the families of the pilots. But that's, as a physician, we work in an environment where we rely on information, and this is deeply important. So, okay, well, we can invite you back at the end when there are questions. But thank you very kindly. That's excellent. Appreciate it.
Thank you.
So before we turn to sort of an overview of the consensus statement, I want to welcome 3 people, and you see Seema and Carl and Jody there. So what we've done is we've invited 3 clinicians here, and we may start with Carl because I know he's on call today and may have an emergent C-section that he's planning. So we learned this just before. But I'll just briefly introduce them, and they're going to talk about their lived experience as clinicians with working in a fragmented or maybe not optimal data environment. So Carl, we'll start with you. Carl's an OBGYN. He is born and bred in Alberta. He is currently working in northern BC, and he's actually a member of one of the leaders of Network Health BC. and has a growing and abiding interest in data governance. But initially, as a self-professed geek, he sort of fiddled with the technology and so forth. Seema is a social worker. She also is from Alberta. Well, they're all from Alberta, and but is currently doing her master's in social work at McMaster, but has been working prior to that in Calgary. And Jody is with she's a registrar at the College of Physiotherapists of Alberta, but a physiotherapist with a long history of working across a range of clinical practices in Alberta. So basically we want to say, so you heard what Nikki said. She said, we need this data. It appears that either not having access or having poor quality data can impair our capacity to provide quality care. We'll start with you, Carl. Just a few minutes about your experience, your personal narratives around this.
Well, I mean, I can give you a really good example because about 20 minutes before this webinar started, I got a phone call with a critical lab result from Canadian Blood Services. And in the intervening, 30 minutes, I found a maternal fetal medicine specialist in one city, another one in another city, a pediatrician, a subspecialist pediatrician, 2 different laboratories, an operating room, and an imaging department. Not one of those people has all of the information they need. It's just relying on me phoning and talking and coordinating all of these people. And it just doesn't work, right? Like the fact that I actually got this phone call today was a complete fluke because I just happened to be in the office and picked up the phone before the webinar came. The only reason they phoned us instead of sending a fax and letting it sit in a queue is because we changed our fax number 3 years ago and Canadian Blood Services didn't have an updated fax number and it didn't go through. So, I mean, this always happens when I do these webinars. It's like right before or right during, I have to pop out and go do a stat section. But it's like, but the reason it happens all the time for these webinars is because this just happens all the time in general. Like this is the default state that we're operating at. It doesn't make sense. We are not going to solve it by throwing software at things. That's not a solution. We've tried that. The only way we're going to solve it is if everyone is aware of the problem and everyone is going to work together to solve the problem. So I think this consensus statement is a huge step towards that, and I'm very grateful that it's been put together and to be here and share experiences.
Thank you, Carl. That's excellent. While you were doing all that, I was running around looking for a hotspot for a phone. And so you're clearly a highly more productive individual than me. And if you have to leave for your patient, clearly that hopefully comes first. Seema, we'll turn to you. Tell us, and again, we intentionally here have 3 regulated health professions represented. But I think we could have asked a member from all 29 to be here. But Seema, tell us your experience.
So when we don't have a full picture of the health data or can't help our patients because we don't have the data, we're really slow to react to policy changes. And so last year, probably why I went to school this year, was the federal government had put in this new program of the disability payment. And so if you had the disability tax credit, you could get it. But what the Alberta government did is, because of this new program, they decided to cut their AFRHP program by the same amount, right? So the government was giving $200 a month, the federal government, and then the provincial government cut it by $200 a month. And so when you're living on AFRHP, so AFRHP is Assured Income for the Severely Handicapped, for those joining us not from Alberta. And it was horrible for our patients. They came in, I was working in primary care, I was Mosaic Primary Care Network. They would come into the office, they would be so upset because they didn't need the disability tax credit before. And so I'm like, okay, well, we can fill in at least part of it. And then you have to go to the doctor to fill in the rest. And these poor people, they're like, you know what? Forget it. I am just going to I'll just live with $200 less. I'll figure it out kind of idea. And so like, what does that do as a professional, right? It's like, no, like we can start it, we can try. And then they're like, okay, calm, we'll try. And then I have to break the news that when you go to the doctor for them to fill out the Part B, it's going to cost you, anywhere from, $100 to $300, depending on what doctor you have. And then
why were you not able to fill it out?
Because you need the doctor, you need the patient's information to fill it out. So to put in their disability.
Okay. So you didn't have access to that?
No, we don't. As social workers, we're not even stewards. So we could fill out the demographic information, all of the information you need to steal their identity, that we have. Their ID, their healthcare number, sometimes if we have to pay for the forms, the credit card number, everything like that we can have. But like the information we need to fill out the disability form, even though like we have 45 minutes, we can sit with them, we can go through the record, make sure it's accurate, make sure there's no mistakes in that 45-minute appointment. But instead, I have to send them to the doctor, let them know that AFRHP will pay for the doctor to do the form, but they have to pay for it up front, right? And if they don't, then the doctor's phoning me, and then I have to phone the government, and then this whole thing can take up to 3 or 4 days just to get this stuff submitted. And you can understand why people are like, no, I'm just going to walk away from this.
So you could do it if you were part of the patient's circle of care and had access to the information. You are part of the patient's circle of care, but you were restricted from certain aspects of their information.
Yes, if the patient could just say, hey, you know what, here's my information, can you put this in? I can put my name, my registration number, and send it, and then just, it's done. And like I said, we can go, I have 45 minutes, you have like what, 8? And we could go through it and sit with them and make sure everything's okay.
Okay, thank you. So again, it's a matter of access because of you're a non-custodian. So you have access to certain information, but not others, and also a lack of integration of digital health systems. So Jody, I think your experience as a physiotherapist you are also not a custodian, and in Alberta, I think 11 health professions are custodians and another 18 are non-custodians, and this separates us in terms of what information we can access. And I think many professionals may not know that there are different designations, and so maybe you can talk about your experience with that.
Yeah, thanks, Ewan. I'm sort of thinking my experience goes back to me being a clinician as a physiotherapist, as well as regulating a profession that practices under a very complex privacy framework. So as you mentioned, physiotherapists aren't designated as custodians under the Health Information Act and have to navigate 4 different pieces of privacy legislation, all depending on where they're employed or the patients they see. So as a result, the physiotherapist's access to health information and their ability to contribute their clinical information to a health record really depends on the practice setting that they're working in, rather than their role in patient care. So many physiotherapists don't have access to hospital records, test results, surgical reports, physician notes, and they can't contribute their clinical findings back into the patient's health record unless they're working as an affiliate in a custodial setting. So obviously it creates a bit of a disconnect when physiotherapists are delivering care without access to the full clinical picture. And I think Nikki had commented on that in her presentation as well. I think the biggest example that we often use is there's post-orthopedic surgery care. A patient might be discharged and sent to a physiotherapist, and the physiotherapist doesn't have access to the surgical report or possibly any post-operative restrictions the patient might be under. And so with that, there might be a delay in the care that they receive. It might be modified conservatively to adjust for that, or really rely on incomplete patient reported information back to the physiotherapist. And I think also, again, Nikki had demonstrated some of the harms that could result from not having all that information. I think the biggest thing that we also do see is that patients reasonably expect that the physiotherapist can see all their relevant health information, and their recovery progress is also shared back to their broader healthcare team, when in reality, the physiotherapy records might never be part of the health record, and patients are often put in a position of carrying their information back and forth between the providers. And so I think it creates some confusion for patients who expect that their care is coordinated across their providers. In that, I think that networked health has highlighted the reports of disconnected information leads to disconnected care, and physiotherapy and social work are examples of how exclusion of providers from health information can create some systemic gaps that affect patient outcomes.
Excellent. So that's really helpful. So I have a question so we have three perspectives here. Seema, you're having trouble providing service that you could provide, but the patient then has to go and see another provider, a physician in that instance, simply because you don't have access to the information they need to fill out this form. Jody, you depending on where you work as a physiotherapist, if you're working as an affiliate of a custodian, you have access to some information. If you're in a private clinic, you have access to different information, and your obligations to different legislation differs depending where you might happen to be located. So for you, as a physiotherapist, for the same patient, you may or may not have access to net care depending where you might happen to be working on a given day, I believe.
Correct. Yeah. So the patient, the information doesn't follow the patient. It basically is based on the institution or the practice setting that patient has been.
Right.
So we don't have access to net care if you're working in a private practice setting, unless you're working as an affiliate.
Yeah. And Carl, you've explained very clearly that the on a day-to-day basis that you're dependent on this information, and I think you've said at times to me that it can be a frightening thing. So I just wanted to say, does burnout or frustration play a role in this as providers? Is this something that occurs?
Oh, totally. Like I experienced that firsthand. This is an Alberta webinar. I'm not in Alberta, but I did train in Alberta, and where I am now, the data are even more fractured than in Alberta, Saskatchewan, and the Northwest Territories where I had trained. And honestly, if I want to provide the same quality of care that I did in those places where I am now, I was finding myself, by the time I aggregated all the information I need, double check the things I was used to double checking, and so on, it was 2 a.m. that I was finishing clinic. And so ultimately, like, I had to realize that that's not sustainable. We can't do that. I'm not saying, here is perfect or Alberta is perfect or not perfect. No matter where we are in Canada and across the world, there's a lot of room for improvement. Data always has borders, and we need to find a way to make it not have borders so that we can do our job correctly.
Yeah. Okay. So one last question for you. I mean, this consensus statement is concerning Alberta and so forth. Do you think that this is an endemic problem in Canada, or is it restricted to any given location? Whoever wants to, or do you have any opinion about that?
My audio just cut out there for a second, and so I missed your question.
So is this problem restricted to Alberta, where the consensus statement is, or is this a problem beyond? Is this a problem endemic to Canada? What is your thought?
It's a problem endemic to everywhere, especially Canada. I think as Canadians, we need to expect more from our provincial and federal and public institutions in general, because I think this problem is solvable. And I think it's overly prevalent here, and it shouldn't be just based on the design of our healthcare system and the Canada Health Act. All of these
Excellent.
things.
Okay, well, thank you kindly. I will let you go, and then and you can come back later. But Jody, if you could stay on, because you are one of the authors of the consensus statement. Thank you very much, Carl. And Seema has so I just want to welcome Glynis Reeves-Gibbs and Melanie Sicott. And so these three individuals are really the authors of the consensus statement. So I'll just introduce them. Glynis is the executive director of the Alberta Federation of Regulated Health Professions. basically the role of the federations is to assist in the coordination of projects and communications between the regulated colleges, professional colleges in Alberta. She also has worked in the field in a variety of capacities for many years. And Melanie she's a registrar and the CEO of the Alberta College of Speech Language Pathologists and Audiologists. And she joined the staff in 2021, and she was appointed registrar in 2024. And she's studied in a variety of places, including McGill. So we share that, Melanie. I never knew that. Thank you. So this consensus statement, which again we've established is a new thing, where all 29 regulated health professions come together, or 28 and a half, or whatever it is. And Terry, if you can share the slides here, that would be great. So we're just going to talk about what you hope to achieve with this. So we'll start with you, Glenys. You know, the consensus statement. Why don't you give us an overview of the purpose of it?
Thanks, Ewan. Well, as you mentioned, the Federation represents 28 of the health profession regulatory colleges in Alberta. And what we do, as you mentioned, is sort of try to have a common voice for issues that may affect all regulators in the province. Many people don't understand that the primary focus of a regulator is public protection. And this is done through the implementation of applicable legislation through processes such as standards of practice. As we've already talked about in this webinar, all health professionals rely on high quality data to provide safe and effective care. And so when data is poorly integrated or not available, it can put individuals receiving care at risk. So when we started to talk about this, and where you were able to present to our group on this, we really felt that strongly that there needed to be a unified voice when speaking to the need for effective data sharing. And so thus there's where the support came to develop the consensus statement.
Excellent. Now, again, it has to be acknowledged that as has been said, and I think Nikki said, and others, the colleges do not regulate data. There is no role there. I don't know, Melanie, if you want to speak to that.
I can just speak to that briefly, Ewan. I think that that's an important thing in the development of this consensus statement too, is that the regulators definitely recognize and have recognized that we don't regulate data. But I think what's exciting about this consensus statement is that we have recognized collectively and just seen the importance of it for all the regulators, of the fact that the quality of the data and the ability to access that quality data is integral to the ability of our registrants to provide high quality, safe care for Albertans. And I think that really ties in with the research that Nikki did and that she presented earlier, just to how important that is. So yes, regulators, we don't regulate data, but we recognize how important it is for the protection of the public and to our registrants being able to provide safe, high quality care.
Right. And you know, often we get the question at Network Health, who does regulate data? Well, data is regulated through the Office of the Privacy Commissioner in part. But what is interesting, and they do an excellent job, the Office of the Privacy Commissioner, they regulate data with respect to privacy, access, and issues around that, right? But the regulation of health data to ensure it is used to promote and foster the health and well-being, and for instance, that it is accessible, that it is high quality, largely doesn't occur. There is actually no one accountable for that in most jurisdictions in Canada. So let's move on then to what the consensus statement is short. It's about it's 2 pages, and thank you, I think, Jody and Melanie, for cutting it back and making it succinct. So maybe, Jody, you can speak to the key issues that it addresses, or all of you can, whatever works.
Yeah, I think we had really tried to narrow down. I mean, obviously there's issues beyond this, but we did try to narrow down the issues that you have presented on your slides. So we recognize that health data is important for quality care and can cause harm to individuals. There's no unified health data strategy we know of, and oversight over the health data. As I spoke to in my part of the presentation, the legislative framework. So, we really have separated from divided health professionals into custodians and non-custodians, and that impacts the information they have available to them. And then the professional standards. We set standards of practice for regulated health professions, and there's expectations set within those standards. And we are hoping that, we could harmonize some of those standards across the colleges, because all of the concerns that we've raised throughout this presentation are presented for all professions.
Yeah, excellent. And let's talk about the standards a little. The most regulatory colleges, have standards around continuity of care, right? And we recognize continuity of care promotes quality health services and protects the public. And yet there's no informational continuity. Often it's broken through different platforms and different EMRs and different lab information systems and so forth. And there are a lot of efforts to begin to try to marry these. So the regulatory colleges traditionally then have not aligned these standards of practice around continuity of care, is what you're saying.
That, and I think even our privacy, our documentation, records retention policies, all of those are very different, because we do have health professions that are under different pieces of legislation, and obviously have to set expectations based off of the legislation in which they need to function.
Right. So it becomes challenging within that sort of fragmented legislative environment to do this. But you were suggesting that the hope is that, well, we'll get to the recommendations, but the hope is that there can be some alignment. So that's excellent. Do Melanie and Glynis any further comments about key issues, or are you comfortable with this?
I think Jody's covered it off well. Thanks, Ewan.
Okay, so we'll move on then. And this actually, this is just a slide just for those of you, we've been talking a lot about the different legislative accountabilities of different professionals. So here in Alberta, and it differs from province to province, I think in Ontario, every single health professional is a custodian. In Alberta, they're split up. And which is exactly what Jody has been referring to, and this leads to some informational problems. People talk about patient-centered team-based care a great deal, but again, team-based care becomes challenging when the members of the patient's team may not be able to share information between them. And I think this is the point that you guys are trying to make. So let's look then at the recommendations. And Glynis, why don't we go back to you as the boss here, as the executive director.
Oh, I don't think I'm the boss, Ewan.
Yeah.
Mm-hmm.
So yeah, it's a voluntary organization. I recognize that. I say that with all fondness.
I know. So I mean, really, when we, I'll let Jody and Melanie talk more to the exact recommendations, but really, I think when we started to look at the purpose of the statement is that even though, as it's been mentioned before, health regulators don't regulate health data systems, they are the ones that are putting in those standards of practice, professional competencies, and enforce all of that to ensure that there is public protection. And so really some of the recommendations, what we're hoping is that these will move forward, because colleges would like to demonstrate that they are in consensus when it looks at how to approach and achieve informed and evidence-based digital health professional regulation that supports the mandates of all colleges in Alberta. And this is an issue, as we said before, for all health professionals. It doesn't matter which college you're with. And so once again, our recommendations are that unified voice of things that we'd like to see move forward.
Excellent. So I'm just going to focus on a few of these. The provincial health data strategy. I mean, so clearly, if I understand correctly, this puts the regulators sort of in a strange place because there's no authority to oversee data, but the members are dependent on it. So traditionally, I don't even know if regulatory colleges can be advocacy groups. I don't think it's or there shouldn't be. That's not the role. So how do you navigate that where you have no authority over data, but you recognize that this is a problem? Does that make sense? Any thoughts on that?
I can start with that one. I think, as the consensus statement was released, it was clear that regulators felt there was some voice for us to have in these discussions because it does relate to public protection.
Right. So it's fairly cut and dried in a way, Jody, that you can't, your capacity to regulate your members to protect the public is circumvented if they don't have the proper tools or the environment or the conditions, or as Nikki said, the system-based issues that impair their capacity to do so. And that's what this is stating. So this appears to be a big problem. There's a study that came out from 2 Alberta-based health economists last November that suggests that the fragmentation of health data is costing the country $9.4 billion a year. So this isn't a subtle thing. The other way there's a health workforce crisis in Canada, and you hear from members that they can be frustrated. Do you hear about issues of burnout related to health data from your members?
Maybe I can speak to that a little bit, Ewan. I can say, and I can just speak for me personally, is that I would say for our professions, the link to burnout is not what I hear about. I think I've said to you, Ewan, and Jody and Glennis before, that the professions that I regulate and am involved with every day, they're sort of used to the status quo now. So they often don't call us talking about their frustration about, how this is leading to burnout, but they call with frustrations around. I did hear from an audiologist recently who talked about spending days trying to get access to records that they needed, and it came in and it was hundreds of pages of fax that came in on their fax machine, and then spending hours trying to go through to find the bits of information that they needed in order to be able to provide the care that their patient needed. And they didn't link it to burnout, but you hear it in their voice. You do hear them say, I don't have time to do this. Do you know of any better way that I can access this information that I need to make decisions? So I don't think, unfortunately, I think there's a status quo issue here that people are used to this is the way it is. And it's just that onerous to get the access to the data that you need to provide effective quality care for your patients. And you hear it in the fatigue in their voices, but they aren't necessarily, for the professions I regulate, tying it to burnout. But in their voice, I always wonder about burnout as I hear it in their voice, and I hear the frustration, and I hear them saying about working late at night and the hours of their lives this is taking. So, and not exactly addressing your question, Ewan, but that's a perspective coming from the profession, the healthcare professions that I work with.
Jody, you were smiling. Do you have anything to add on that?
Yeah, I was just laughing at Melanie's point about frustration, because I do think that's what we probably hear from our registrants as well. Not necessarily using the word burnout, but some of the loopholes they need to try to explore to be able to get access to information. And I think I mentioned to you, Ewan, a lot of physiotherapists may find workarounds, and with my health records, they just rely on the patient to pull up test results so that they can look off on the patient's phone to access some of the information they might need to provide care to that patient. So I think there is some elements of frustration that we often hear.
Excellent. So I just brought up this slide, which I was going to show, but I didn't. And we'll open this up. And if Nikki and Carl and Seema wish to come back, Carl may have had to go to his C-section or whatever. You talk about, accommodating. Oh, there's Carl. Excellent. And Nikki's there. Good. I had teased Nikki before this. She had to do her hair like Alfred Einstein, but she didn't. So I'm very disappointed with her. This is a 2023 survey about another health profession, nurses, from Canada Health Infoway. And around 2,000 nurses were surveyed. They said 44% of the time they had to seek information about their patient from another service that they did not have access to, and on average spend 60 minutes a day looking for information from other services for their patients. If you prorate that to the number of nurses in Canada, and I think there are around 320,000 nurses, this is every day 40,000 nurse equivalent positions looking for information. It's pretty shocking, and you begin to see why this is costing billions of dollars and leading to frustration and burnout. So I'm going to open this up. If people have questions in the last 10 minutes here, I'm just going to see if there's anything here. You can put them in the link. And I see there are lots of comments here. Dania, there is also an issue with, so here we go. Isha Sharma, do we have information on what kind of information they're looking at? Are they labs or reports, etc.? So I don't know what you mean, who they is. Like clinicians? You can add something in there if you wish so that we understand what you're asking.
If I can
if
offer something, sorry.
Yeah, go ahead.
I was just going to say, if I can offer a little bit.
Yes.
It depends on the profession and what we're doing with that information. For me, if I'm filling out a form, I need to know all the patient's deets, basically, like like their name, their Alberta healthcare number, and anything they need to interact with the government for. So the patient usually has that. But if I'm filling out a disability form, then I need like their medical record, right? Do they have a disability like autism or a broken leg that's temporary or that kind of thing? And then to George's point, I'm also in the community. So if I'm doing a discharge, then I need to know all of the social services that would interact with this patient when they're going back into the community. So I think George had a comment about social data, which is exactly, as a social worker, what I need when I'm working with a patient in the community. So I hope that helps a little bit.
Yeah, and I think I misunderstood that, and people have clarified it. Isha, you're asking about what the nurses were looking for. So this, you can find this. This is on Infoway's website. It's a 2023 National Nurses Survey, and they asked them, this is just any information that they require for a patient from another service. So whatever that's the bucket that they're looking for. Now, understanding George is here and making comments. George, I'm going to ask a question on behalf of George. Is this problem just restricted to regulated professions? I mean, the Alberta Federation of Regulated Health Professions exists and brought the regulated professions together. However, many healthcare services are provided by non-regulated healthcare providers, community-based services, so forth, who require information as well and are members of the patient's circle of care. So, does anyone have any comments about that? Do you think this problem is uniquely for health professions? Any comments?
Absolutely not. Like it's for, like, if you're going to the Center for Newcomers and someone's trying to help you fill out a form, like they might not be like a registered health professional, but they still have to help you, right? And in a different language usually. And then where the different services are going, right? If they're seniors, they need seniors care, they need all of these different things, but they might not be a registered health professional, but that information is still really important. right? And especially like with the unhoused population, if we have to follow them for any reason, a lot of people who work for those organizations also aren't regulated. So then, we're constantly chasing data if something happens, or if they're brought in by the police, or like those types, or if they violated part of the Mental Health Act. So sorry, I could go on forever. Social worker.
Yeah, but and you interact, Seema, a great deal with non-regulated healthcare providers, and I know George Alvarez and his the individuals he's working with, Converge, and others are certainly working towards building out more connection. And again, this is this notion of person-centric health data architecture, that we actually the information is surrounded. Is the patient is the center of their information, as opposed to different health services, as you said, Jody. So Greg Steer asked a question: are you planning to address questions submitted with registration? Does anyone have anything to say to that? I think we're talking about, Greg, all forms of health information. And what's very important here is to understand that in no way is there a suggestion that the privacy, security, or accountability to Health Information Act is circumvented in any way. But there must be a means to share information around a patient's circle of care and through their healthcare team that allows that allows for excellent quality of care to be given. And as Nikki pointed out, that appears to be at risk here. So another question then here, and maybe this is more for Jody and Melanie with respect to this, and others. So there are other colleges and there are other federations in Canada. You have said this is not restricted to your census. This is not an Alberta issue, it's a Canadian issue. And Carl, I think you suggested it's maybe an international issue too, with digitized systems. Is there a value in bringing this message to other colleges, to other federations in other jurisdictions? And three of you, Nikki and Jody and Melanie, work for colleges. Do you have any thoughts on that?
I think certainly there's value in bringing this to other colleges, other regulated professions, not just in healthcare, as we've mentioned already. And I think too, just from someone's earlier question about, is this restricted to regulated professions? Certainly I deal kind of in the realm of physicians. So even thinking about, admin support when you first go into a clinic, that's not a regulated profession, but the admin person needs to have access to data as well to understand what the patient is presenting for, to understand the time required, et cetera. I did also just want to point you into a question that I thought we could perhaps try to tackle in the last minute here. Sure. From Christiana, who asked, given the collective expertise on this panel, what strategic levers should we be prioritizing to advance true data interoperability, ensuring clinicians have seamless access to the right information at the right time to optimize patient care while reducing burden on the workforce? So what levers? Yeah.
That is a brilliant question, Christiana, and that's fundamentally it. So I think what Jody and Melanie and Nikki are saying with respect is sort of trying to spread this message, first of all, around the consensus statement. There's a role for regulators to play here, saying we need to advocate for coherent access, quality, and use of data by our members in order to protect the public. So that's the lever number one. Number two is that this is the work Networked Health certainly has engaged in. And there is a lot of work going on in Canada beyond Networked Health. Bill S5 was just introduced by the federal government, which is the Connected Care for Canadians Act. We all need to engage around that. They will be developing regulations. So I would encourage you all, if you're interested, to reach out to us at Networked Health, because this is fundamentally what we're trying to do, and we have a lot of work coming that is focused on that, and are working with organizations like the Alberta Federation of Regulated Health Professions to promote this way of thinking. And this is, so fundamentally it's about cooperating around all of this, and working with our non-allied health professionals like Converge is doing, and so forth. Any other comments? Nikki, do you want to respond to that as well?
No, I think you gave a great response, Ewan. I'm just cognizant of the time.
Yeah, and we're at time, so we have to. So thank you all very much, and appreciate the panel. Thank you to Terry Price for running the behind the scenes thing, and it was a bit chaotic with people being in faraway places without proper internet connectivity. Carl, you got to get to your C-section. Very much appreciate this, and we hope to see you again at a forthcoming webinar. And if you do belong to a regulator and you wish to reach out to us either in other provinces or in Alberta, but we're certainly happy to discuss how to move this all forward.